let's cover the classification of the different types of DM. Now, type 1 DM, strictly put, means a beta cell defect or failure. Primary, meaning the beta cells are the problem. It usually is immune-mediated. That's the majority of the cases, but it can also be idiopathic. By immune-mediated, I mean we can detect autoantibodies against the beta cells themselves. So type 1 is destruction of the beta cells, usually autoimmune. That's type 1A. But there's also type 1B, which is idiopathic, meaning the beta cells are being destroyed, but we don't know why. Type 2 DM is insulin resistance. Insulin resistance means the cells are not responding correctly to insulin. And this could be with inadequate secretion or excessive insulin secretion or normal insulin secretion. In other words, type 2 DM, the beta cells are there. They are working away, but for whatever reason, the insulin they are making is inadequate or normal or excessively released, and the cells of the body are not responding appropriately. You need to start thinking receptor defects. So with type 2, the important distinguishing characteristic is we have beta cell function of some type. Then the DM other types that you see here, this is basically where we recognize, for example, it could be other endocrine disorders like Cushing's syndrome. A person with Cushing's syndrome has excessive glucocorticoids. They are diabetogenic. The person doesn't have diabetes officially. It's secondary to some other endocrine disorder. It could also be secondary to a pituitary disorder that leads to excessive GH, growth hormone, which leads to gigantism or acromegaly. So a person who has excessive growth hormone release will also have a diabetogenic effect. They will present with elevated blood glucose levels, but it doesn't mean that they are overtly having diabetes mellitus. The DM is secondary to some other problem. Additionally, in this category, we can have beta cells being compromised because of drugs that are being taken, like interferons. If the patient has cancer, some other drug the patient is taking is causing the disruption of insulin. It's causing the disruption of the glucose metabolism. If you were to remove that drug or that insult, then you would predict they'd be okay with their glucose levels. So there are a whole bunch of different scenarios that fall into place for this, quote, other DM, unquote, category. There's another type that falls into, quote, other forms called MODY. It stands for Maturity Onset Diabetes of the Young, and I'll explain that in just a little bit. These other forms are really called secondary diabetes. The diabetogenic effect is secondary to some other problem. Now, another type is called gestational diabetes. Hey, you know what? If you wanted to be technical, you could call gestational diabetes as secondary diabetes mellitus. Yeah, it's secondary to some other initial problem. What's the problem? She's pregnant. Mom has diabetes. It became a problem because she got pregnant, and when she delivers that baby, she will not have the problem of diabetes. Or will she? That's the interesting thing. Will she be free of the diabetes? That's not necessarily the case. Actually, having gestational diabetes is nothing we take lightly. As future nurses or PAs or MDs, a mom who has gestational diabetes, that's considered a high-risk pregnancy. We treat her as if she's going to have a frail baby. We treat her as if she is frail, because if we don't, the outcomes are not good. So we err on the side of being conservative. We go full tilt trying to lower the blood glucose levels in that mom, because that's going to improve her health and the baby's gestational health. And I'll talk more about that when I get to that slide. Alright, so let's talk about type 1 DM. This is a beta cell failure. We cannot attribute it to some other insult or explanation. Most of the time, type 1 is going to be type 1A, which means immune-mediated. Now, what does that mean? Okay, so two distinct types of type 1 diabetes have been identified, immune and non-immune. In immune-mediated DM, environmental and genetic factors are thought to result in cell-mediated destruction of beta cells. In the common form, markers of immune destruction, this would include autoantibodies to islet cells and or to insulin and or to glutamic acid decarboxylase, or GAD, which is a very common enzyme in the beta cells, and are found in about 85 to 90% of the individuals when fasting hyperglycemia is initially detected. Now, it turns out that there are human leukocyte antigens, or HLA, DR4, that are strongly associated with this phenomenon, and HLA DR3 markers are also associated with diabetes and other autoimmune disorders like Graves' disease, Hashimoto's, and Addison's disease. If the patient has the gene for DR3 on one chromosome 6 and the gene for DR4 on the other chromosome 6, then they actually have a 20 to 40% chance higher of getting type 1 diabetes than the general population. The patients with these genes are more prone to developing autoantibodies. If they develop islet cell autoantibodies, we call this ICA. And grouped into this, we have antibodies against glutamic acid decarboxylase, a very common enzyme used in the beta cell. It's abbreviated as GAD. Or another protein targeted within the cell is tyrosine phosphatase, which is abbreviated as IA2. So these are two types of proteins targeted by the ICAs. We also can have antibodies against insulin itself. These are called insulin autoantibodies, or IAA. In this picture, you're seeing a pancreatic islet cell, a beta cell, presenting with its antigens, and a CD4, a T helper cell, presenting that antigen aberrantly to other immune cells of the body, like the cytotoxic T cell. And that starts destroying the beta cells. Now, the idiopathic type, we don't really detect antibodies. It could be viral-linked exposure to rubella or cytomegalovirus. It could also be exposure to drugs like rodenticides, drugs that are supposed to kill off rats, etc. It could be exposure to drugs like aloxin. There are lots of drugs that, for whatever reason, cause the destruction of the beta cells. Now, in type 1 DM, we need to be very, very careful with the ketoacidosis. This can be very profound in an acute amount of time. With type 1, patients usually present with insidious onset, acute and strong. The patient is being brought in by their parents, usually because they're younger, and they're losing sleep at night because they're urinating, they're hungry all the time, and they want water all the time. The kid is complaining about being hungry, and the kid is calling out in the middle of the night for the water. The child has been using fats as an alternative fuel source, and they will be in a state of ketoacidosis. Look at their respiratory rate. It's probably going to be high because the respiratory system will try to compensate for the acidosis through hyperventilation or Kussmaul breathing. They're probably going to have tachycardia. They're probably going to have sweet breath. The kid is going to smell like they have morning breath, and it'll be in the middle of the afternoon, even with brushing their teeth. So ketoacidosis is going to be a huge problem with patients with type 1 DM who are not controlling it with their insulin injections. Now I'd like to talk to you about type 2 DM. Again, out of the 20+ million cases in the U.S., about 1 million of those cases are going to be type 1. The rest are type 2. And you know what? The incidence of type 2 diabetes continues to go up despite our efforts to educate the public. The cause of the common form of type 2 DM is really not known. The genetics of this form of diabetes are complex and not clearly defined. It affects people primarily over the age of 40 years, many of whom are obese. But that does not mean it precludes itself to people of 40 years. No. Children are becoming obese in this country, and our children are presenting with type 2 diabetes. What's even worse, children with type 1 diabetes are taking their insulin, but they have crappy diets, and they're not exercising enough, and they are becoming obese. And now we're seeing a type 1.5 Actually, I've seen 1.5 described as many other ways. It's just a kind of hit phrase. Anyway, where the person is insulin dependent because they have pancreatic beta cell failure and they need to supplement with insulin, that insulin they are injecting is no longer effective because of their obesity. A healthy lifestyle, dietary restriction, exercise, weight loss, weight management, all are key to health and reduce complications later in life. It really is. Dietary restriction, reducing the amount of what you eat by about 20% will prolong your life, reduce your incidence of cancer of all types straight across the board, reduce your incidence of DM, reduce your incidence of all complications resulting from cancer and diabetes and congestive heart failure and coronary artery disease, etc. Simply by watching what you eat and the amount of it. It's not about a diet and being on a diet. It's about having a healthy awareness of what you're putting in your body. With type 2, insulin resistance is heightened by obesity. Inactivity, illness, medications, and age, all of those are going to lead to insulin resistance. A significant body of evidence has accumulated that indicates that defects in insulin secretion can lead to insulin resistance and vice versa. If you have defects in insulin secretion, you will have defects in insulin responsiveness, and defects in insulin responsiveness will lead to defects in insulin secretion. In a type 2 diabetic, there will be a postprandial glucose level and eventual increase of glucose production by the liver. Basically, the cells are starving in the face of plenty, just like in the type 1 diabetic. They're making insulin, just not responding to it adequately. So the liver is going to be hit by the alpha cells because the alpha cells, which are insulin dependent, are not responding to the insulin, and they are releasing their hormone glucagon. So these patients are going to have a hepatic response and result to that insulin resistance. Now, along with type 2 diabetes, there is an increasing amount of evidence to suggest that insulin resistance is not only contributing hyperglycemia in persons with type 2 diabetes, but may also be implicated in other metabolic abnormalities. So when we're talking about metabolic syndrome, we're talking about a person who presents with several of the following symptoms. They have central obesity, or quote unquote the apple form of obesity. The obesity is mostly in the abdominal region. I'm showing this to you as a cartoon with an apple, but look at the man in the top right picture. I mean, he really does look like he has that apple type of presentation where his fat is localized in one area. That is a huge indication of metabolic syndrome or type 2 diabetes. Along with this is a high level of triglycerides, low levels of high-density lipoproteins, HDL, or the low levels of our good cholesterol. Hypertension, systemic inflammation, and this means we can detect it clinically with high levels of C-reactive proteins. We also can detect abnormal fibrinolysis, abnormal function of the vascular endothelium, and that's what I mean by microvascular disease. This means we're going to have a problem with transport of nutrients, gases, etc., thanks to Fick's law. Any time you have a thickened distance for something to travel through means you're going to impede its rate of diffusion. Macrovascular disease means in distinct blood vessels we're going to see plaque buildup. We're going to see atherosclerosis in the coronary artery serving the heart. We can see this in the cerebrovascular vessels serving the brain, leading to stroke and eventually peripheral arterial disease. So in some nations, they refer to this as metabolic syndrome. Instead of metabolic syndrome, it might be referred to as Syndrome X. We're getting away from Syndrome X. Some nations also call this chaos syndrome, where C stands for coronary heart disease, resulting from blockage of the coronary vessels. H stands for hypertension, chronic hypertension. A stands for adult because they needed something for A. O stands for obesity, and the S stands for systemic inflammation. Some places, some physicians call this diabesity, which means morbid obesity, which leads to diabetic effects. Type 2 diabetes, along with these other signs and symptoms, low HDL, hypertension, high triglycerides, all that. The high triglycerides have a lipotoxic effect to the cells that can exacerbate the problem, etc. All of this. So, very interesting, metabolic syndrome and having type 2 diabetes. It's very interesting. Now, listen to me. Metabolic syndrome does not mean pre-diabetes. Metabolic syndrome means the patient is likely to present with DM type 2 along with other signs and symptoms. Hypertension, pro-inflammatory, problems with fibrinolysis, prone to blood clots, a whole constellation of problems go along with this. Obese people have increased resistance to insulin, and they have impaired suppression of glucose production by the liver. They have impaired suppression of gluconeogenesis. This leads to diabesity, and they need to be on nutritional therapy management. They need to learn what foods they should eat, the time of day they should eat them, and what order they should eat them, etc. There is a chart in your chapter which describes a third listing, the quote-unquote, the other types of diabetes. And by other, we are simply saying the diabetes is secondary, meaning something else is causing them. How can we have other types of diabetes? There can be pancreatic disease. We certainly know of other endocrine diseases that can lead to a diabetogenic effect, like notably Cushing's syndrome, but let's not forget pheochromocytoma, where norepinephrine and epinephrine are released, and we recognize that both in Cushing's syndrome, that's elevated cortisol, and in pheochromocytoma, which is elevated epinephrine, that these two hormones are going to be counter-regulatory to insulin. Another interesting type of diabetes is the monogenetic defects. By that I mean, in these types of diabetes, there's one problem. There's one genetic mutation. It's not polygenetic like type 2, where the person might have cardiovascular disease leading to atherosclerosis and increased cholesterol. Polygenic means many genes that predispose a person to having the cardiovascular problems. Now with MODY, which stands for maturity onset diabetes of the young, it is an autosomal dominant mutation. It's a mutation in the glucokinase gene. Now interestingly, the glucokinase gene is the gene that codes for the glucokinase protein. I'll remind you, insulin, in order to be released, glucose from the bloodstream that has to enter the beta cells first, right? It has to enter. The first step when glucose enters the cells is it has to be phosphorylated, and glucokinase, the enzyme, it does this. Otherwise, glucose can diffuse right back out of the cell. So by phosphorylating it, we trap it, and that means in the beta cells, your insulin will be released. Well, if you lack this enzyme, you can't trap the glucose, and that means you can't release the insulin appropriately. Now, other problems can cause diabetes as a secondary issue. Loop diuretics, like furosemide, that target the thickest end of limb. This causes a profound loss of potassium, and if you lose potassium, you're not going to have that gradient for potassium to come into the cell. Instead, potassium is going to shift out of the cell. And I'll remind you, for insulin release, we have to have potassium trapping. So if we have a decrease in extracellular potassium because of a loop diuretic, there's going to be a more favorable shift of potassium from within the cells to outside to the extracellular fluid. This, of course, means we will not be changing the resting membrane potential in the beta cells, and we will not get the voltage gain channels to open, leading to insulin release. So that's just highlighting a few of the other secondary types of diabetes. Now I would like to talk about gestational diabetes. First of all, let's start with a woman who gets gestational diabetes. That means she has elevated blood glucose levels while she's pregnant. Now, risk factors can lead to this, and they are that the mom was obese before she even got pregnant, or she had advanced maternal age, or she has had multiple pregnancies, like more than 5, or she's Hispanic, Native American, Asian, African American, or she had a previous pregnancy where she already had gestational diabetes. If you already had it once, it's almost 100% certain you will have it with every subsequent pregnancy. So I have to tell you, I still remember to this day when I received a phone call from my doctor's office regarding the results of my oral glucose tolerance test. And I remember talking to the nurse and her saying, "Well, it came back that it was diabetes mellitus. You're just a little bit over, Kara, but we don't play around with this. And you're a little bit over, but you're still over." I remember being on the phone with her for a little over an hour, and I said to her, "There is no way I could have gestational diabetes. I take too good care of myself to have this." So when she called to tell me this, I was instantly filled with fear because I knew of the potential complications, and I, my son, both of us would have to deal with this. So I said to her, "You realize that by you telling me this, that my son and I will have about a 60% chance of having type 2 diabetes and a 40% chance of type 1. And for the mom, type 2 diabetes will likely occur within 15 years of giving birth to said child, and especially once she's over 40. So I don't like these odds, not at all." This did not sit well with me. I was not happy about this. I took it very, very seriously because not only was I at risk for hypertension and preeclampsia, and my baby was at risk for fetal abnormalities, I don't want this long-term threat of diabetes. I have to tell you, when I went to the dietitian, and I had to go through my nutrition management therapy to change my way of eating, it was hard. I monitored my blood glucose levels about every half an hour. I did not want them over, not one bit. I was totally compliant. I went to my dietitian and nutrition management therapy meetings. I wrote down everything that I ate, the time of day that I ate, and how much of it I ate. The dietitians I met with didn't just tell me what to eat. They told me in which order to eat my food. They told me what time of the day to eat certain foods and which times of the day to avoid certain foods. I mean, this was remarkable. So, anyway, how can a woman get gestational diabetes? Basically what happens is the pregnancy hormones impede her body's cells' ability to respond to insulin. She's making the insulin, but her insulin receptors are downregulated thanks to the progesterone and estrogen being made by the placenta and her ovaries. So it causes increased blood glucose levels as a result of insulin resistance. Now let's talk about blood tests. Well, up on the screen, I'm showing you a chart right from your textbook. Now, FPG stands for fasting plasma glucose. IFG stands for impaired fasting glucose. IGT stands for impaired glucose tolerance. OGTT stands for the 2-hour oral glucose tolerance test. And you're seeing the cutoff for blood glucose levels on the chart here. The other way that we can diagnose diabetes mellitus is with a casual blood draw. So if they do a casual draw, that means without regard to the last time the patient ate, and if the blood glucose levels come back higher than 200 mg per deciliter, that is suggestive of diabetes. And they will most certainly do a fasting or 2-hour glucose tolerance test to confirm. Some other types of blood tests are the patient monitoring their own blood glucose levels through a glucometer, of course, where they basically prick their finger and draw their capillary blood and touch the blood to a strip, a paper strip, and a glucometer will tell them how many grams of glucose they have, or milligrams, per deciliter of whole blood. Capillary blood glucose monitoring is important for the patient who is diagnosed with diabetes. They need to know from moment to moment what their blood glucose levels are like. Now, interestingly, we can do another type of blood monitoring, which is looking for glycosylated proteins. When blood glucose levels are high, the glucose can force itself to bind to amino acids on proteins in the blood. Now, this can mean the albumin, which is the most abundantly plasma protein, or it can mean hemoglobin A, and that means adult hemoglobin. Either way, the sugar attaches to the globin chains or any protein. If the patient has really high blood glucose levels, even though so high, even their albumin will become glycosylated as well, and even their hemoglobin. We can monitor both. If you look at the bottom left, I'm showing you that you can have normal blood glucose levels, and then we can get elevated blood glucose levels, and that glucose forces itself onto the proteins binding to specific amino acids. We can draw the patient's blood, and we can monitor their glycosylated hemoglobin, and we can monitor their glycosylated albumin. It tells us how well the patient is managing their diet, aka they can't cheat this test. If we see that the levels of glycosylated proteins drop, as shown in the graph on the bottom right slide, it tells us that the patient's nutrient therapy, the management of their nutrients, is working, and that the amount of sugar is less in their bloodstream. And therefore, as there is turnover, new synthesis of albumin, new synthesis of hemoglobins in the red blood cells, in these patients, the proteins are not being glycosylated. So the lower we can get those, it tells us that the patient's actually doing well with managing their blood glucose levels. Finally, we are at the medical nutrition therapy. This basically means dietary management. The dietary management is going to be slightly different for the type 1 diabetic versus type 2 and their age. So what are the goals? Let's not nitpick what exactly are the dietary differences. We're going to want optimal glucose levels, or near normal. That's our goal. We want optimal lipid levels because we recognize with type 2 there could be hyperlipidemia. We want adequate caloric intake. This has to be matched with the needs of the person. How old they are, how active they are they growing? Basically, the end result to all of this is to reduce complications. We don't want the patient to have retinopathy. We don't want them to have the neuropathy and the nephropathy. So a good general rule is the pyramid table for nutrition. The pyramid scheme, as I like to say. We still want most of our dietary intake to be carbs. After that, we want it to be about equal for protein and fat. But the idea is that you scatter your servings of carbohydrate throughout the day and not just have them all at once. For example, you should have about 4 to 6 servings of carbs a day, and you should avoid having your carbohydrates early in the morning because your hormones aren't quite prepared to handle the glucose. The reason is that in the morning you've been fasting all night because you've been sleeping, and you might already have a high glucose count. And I'll tell you about this. It's called the dawn phenomenon. I'll explain this more later. The last thing you want to do during this time is to add more glucose. So in the morning, you're encouraged to eat more proteins and fats, less carbs, stay away from the toast, stay away from the cereal. The other idea is to be mindful of your portions. 4 to 6 servings of carbohydrates really comes down to 15 grams of carbs each serving. Now, what is 15 grams of carbs? And that's where our nation really is getting into trouble with type 2 diabetes and the weight gain. We are overindulging on serving sizes. Something to consider and to discuss with the patient, that once they get on their nutrition therapy, they need to be mindful of factors that can cause their blood glucose levels to drop precipitously. And this can be from accidental overinjection of insulin, just to name one, and I'll talk about that. but it also can result from excessive exercise.